Everyone. Welcome everyone to CSH's Older Adult Training Series. We are a group from Los Angeles primarily, and today we're going to be looking at behavioral health and aging, a deep dive. I'm so pleased to have with us today some of my esteemed colleagues from CSH. I'm going to introduce them briefly and then turn it over to them. We have Patricia Hernandez, who's Associate Director in our New York office, and Ariana Saunders, who is actually with our Southwest region. So with that, I'm going to just turn the program over to them and they'll get started. We do want to just say that we will be recording this. We also will be providing you with a PDF of the PowerPoint later. And we are really hopeful that you will engage during the session by chatting, and we will be watching that and making sure that your questions get answered either during the session or later. So, so please make this as interactive as possible. Okay, with that, I'm going to turn it over to Patricia and Ariana. Thank you.
Thank you, Gretchen. And next slide, please, Holly. So I'm Patricia, and just a little bit about me. So I'm a licensed clinical social worker. So my background is really in working with people with behavioral health issues, whether that's in psychiatric hospitals and supportive housing, kind of all the continuum. So I will hopefully be able to provide some context around kind of the clinical of working with clients.
Okay. Patricia, you broke up just a little bit.
Oh, apologies. Am I back now?
Yeah,
you are. Yes.
Okay.
Okay.
I was just handing it off to Ariana to introduce herself.
I was like, is she done? Let me make sure. Okay. Hi, everyone. Good morning. My name is Ariana Saunders, and as Gretchen said, I'm with the Southwest team. Just a little bit about my background. I've worked in the social service field for over 15 years. Started off in IDD and child welfare, and also for the last 10 years or so have been working in homeless services and behavioral health. And so worked for a while with supportive housing for those with serious mental illness. And then when I moved here to Vegas, I was in New York. And when I moved here to Vegas, did some behavioral health regional coordination and policy advocacy work. So happy to be here, very passionate about making sure folks who are experiencing mental illness get the help and the services they need. And excited to talk to you guys. And I come from the non-clinical background. So I'm here to say, like, you know, you can learn this stuff and still help folks and support the clinicians in all their work. Thanks.
Great. Next slide. So I'm sure most of you are aware, but just a quick note. So CSH, the Corporation for Supportive Housing, we're a national non-for-profit, and we are an intermediary for supportive housing. So what that means, we don't operate or run any supportive housing ourselves, but we really are there to advance the field and make sure that we're developing and ensuring quality supportive housing in communities. And we do this through our training and education center, policy reform, consulting and assistance, and then through our lending. So just a quick note of who we are. Next. So we now want to hear, you know, kind of how do you work with older adults? So if you'll should see a poll popping up. So please choose, are you a social worker, supervisor, peer specialist, case manager? And if you're none of those, you can feel free to share it in the chat. Great. So I see most people, case manager, coordinator, lots of other, and some folks who do housing case management. And I see that there's property manager that just chatted in. So thank you all for being here. And I think a lot of what we're gonna provide is content that can be used across many of these positions. Next slide. So today we have really 4 objectives. So first is really to learn the basics of mental health and particularly its effect on older adults and the aging process. As we all know, people we work with are aging, right? So we have to take that in consideration, especially when there's a behavioral health illness that is present as well. We will also learn how to identify symptoms of a mental illness, including co-occurring disorders, and how to support tenants and clients who struggle with them. So we'll have some case studies that really dig deep into kind of some symptoms of people with schizophrenia, bipolar, et cetera. Talk about implementing best practice for assessing clients' needs and how to engage them around their needs. And lastly, how to navigate some resources. So we have some resources at the end that we will share with you. And as Gretchen mentioned, please, throughout the presentation, feel free to chat in, raise your hand. Whatever questions or comments you have, we're happy to hear them. And with that, I'll turn it over to Ari.
Great, thanks, Patricia. If you can go to the next slide, we're gonna first talk about, as Patricia said, a little bit, just kind of lay the groundwork and some context around the trauma of homelessness and its impact on mental health, share some data with you all just to get us grounded in an understanding of what it's looking like out there in our community and then in our communities and how that impacts folks. So next slide, I'll talk to you. You can go to the next one. There's some data points we just wanted to share about the intersection of homelessness and mental health. And so, you know, as you can see, a significant amount of those experiencing homelessness are also experiencing a serious mental illness. I know that's probably no surprise to a lot of you. And we will talk more about what SMI is and what it looks like and how it impacts people. But I think the key thing here that we really want to stress is just that those that are experiencing a serious mental illness are likely going to need some consistent support and often require more intense services or treatment. And so while, you know, it looks different in everybody and diagnoses are very unique, the symptoms of serious mental illness can significantly impact a person's daily life and their activities, which often then in turn impacts their ability to maintain stable housing, which is why we do see that large overlap of the population. And it's really just important to just always recognize that being homeless or unstably housed really does impact someone's mental health too. So it does become like this, like I like to say, a vicious cycle of somebody struggling and trying to survive and manage their mental health symptoms, also take care of themselves, you know, and often that takes a toll on them, both physically and emotionally. And so the work that you're all doing and that we really advocate for at CSH, I think is just so important because these folks really need that extra support and know that somebody out there is there to support them. Okay, next slide, you'll see that we also want to recognize that we can't talk about the intersection of mental health and homelessness without recognizing how much people are impacted by their experiences in other systems and how it's absolutely impacted by some racial inequities. And so when you think about the demographic makeup of people who are coming into contact with these systems, it often it also becomes very clear that the issue of unmet supportive housing and need for our services is closely tied to racial and ethnic disparities in how these systems function and the outcomes they deliver for our communities. And so at CSH, we got this from our CSH tool that we have, which is free online. If you want to dig deeper into it, you can see if you do csh.org/data, it'll get you there. And we also have the link on the slide that you can access later. But we applied what's called a racial disparities and disproportionality index. And it's really just a methodology for us to take data from all these multiple systems in order to calculate a value for each racial group and ethnic group, and it tells us the likelihood that they'll experience or come into contact with that system compared to the likelihood of people from all other groups. And so you can see in the data above, we've calculated this specifically for California around some of these particular systems. We do it across multiple systems, but we just wanted to pull out these and highlight these for California specifically. And so you can, across the nation, if we look at it nationally, the percentage of people of color experiencing homelessness is much greater than the percentage of their overall national population. And in every state, in our country, Black people are more likely to experience homelessness than white. And specifically in California, you can see that trend holds true. Black people or Black households are more likely to experience homelessness, almost at 6 times more likely to experience chronic homelessness And also American Indian, Alaska Natives are more than 6 times likely to be experiencing chronic homelessness. We also just want to note that often the Latinx data, the Latinx data, or here it says Hispanic is the most undercounted here. And in fact, in your county, in LA County, there was a study done that revealed that they're least likely to be engaged in the homeless service system, and they experience some barriers that you might be familiar with, such as immigration status, cultural language barriers. But still we need to recognize that that is still a group that is probably often disproportionately impacted by some of these systems and barriers to stable housing. You can also see in that index, if you're looking at the purple bars, you know that there's a large disparity for Black individuals when it comes to the justice system, 8 times more likely to be in prison and 7 times more likely to be in jail. And then they're also overrepresented in mental health, aging, and substance use. I do want to note that it's interesting that there are some white individuals are slightly more overrepresented in the aging population. And I think we'll unpack some of that as we look at some of the data that's actually on the next slide. Might explain some of that. So here you'll see, as we talk about all this, we also want to note that it's really important to look at healthcare through an equity lens as well. And so for years, we've seen significant health disparities among Black, Indigenous, and people of color in the healthcare system. I think COVID really, this pandemic that we're going through really helped highlight that, and we're seeing the disparities there as well. But last year, CSH actually partnered with Healthcare for the Homeless Council to look at health disparities among BIPOC individuals. And as you can see from this chart, there's huge disparities, especially pronounced in the rates of chronic disease and disease mortality rates, and also among people of color, and then particularly for those who are Black or African American, American Indian, Alaska Native, and Hispanic or Latinx populations and communities. And then just, as I said from the slide before, as you note, the life expectancy for white individuals is almost 80 years. And so that might be some of why we're seeing them, or you're seeing them more in the aging population in California. Okay. So that laid some groundwork for some data. On the next slide, we just want to reiterate, why we even wanted to talk about that data. And it's really because, every day in our work, the disparities lead to some very concrete outcomes that you're probably experiencing today as you try to engage folks. When you take intersectionality into consideration, it really does equate to people feeling more marginalized, more on the fringe, and feeling less included, and maybe not as easy to access some services. And so these inequities can lead to individuals having more contact with these systems, as that data showed, but it also really impacts to how they experience some of these contextual factors that can directly link to inequities, such as housing, substance use, and healthcare and other employment opportunities that are listed on the slide. So all this leads to community service providers really needing to understand how to address, and not just the inequities, but also these consequences that folks are experiencing, which often lead to the onset of mental illness, and often that untreated mental illness, which begs to be the challenge of how do we support these folks and get them the services they need. And the next slide, just want to also re-articulate how trauma impacts folks experiencing homeless and people's behavioral health or mental wellness. I often say it's kind of a chicken and the egg scenario with folks, the trauma of homelessness, the trauma of poverty and structural inequities, racism, homophobia, all of which can really have generational and historical impacts on folks. But also people experiencing homeless often feel marginalized and isolated and discriminated against. And they're highly vulnerable to violence, victimization, and re-traumatization. So, sometimes just being homeless, regardless of how somebody got there, being that experience can be very traumatizing in itself. And we know trauma absolutely impacts people's mental wellness and and can be, can actually trigger or create the onset of a mental illness and their symptoms. So really want to just recognize that we need to recognize that people might be in this vicious cycle, and the work that you're doing is going to be so impactful as you try to support folks, build their trust, build that relationship with them, so you're able to get them into the services that they really need and deserve, so they can thrive in their communities. And on the next slide, we just want to also recognize that given the current climate and some of the data that we just shared about the inequities, we really have to recognize the impact of systematic racism as we discuss mental health and trauma as well. You know, without taking time to acknowledge these disparities in the homeless system, it really does a disservice to folks, because we have to recognize how much it does impact the people that we're working with. And so one major form of trauma that a lot of people of color or people who feel marginalized may feel is those in those communities is that racial trauma. It does have its own definition. It's not quite, in the DSM 4 or 5, I think we're at 5. It's, but it very much mimics other forms of trauma. And actually there's been some research growing, and more clinicians and researchers are trying to really advocate to get it as its own diagnosable category, because they're seeing that the signs and symptoms associated with this form of trauma is very much parallel, or it looks very similar to other forms of trauma, specifically like PTSD. People who experience this trauma are going to often have some of those same behaviors that you may witness, but also it's really important to acknowledge that because of this trauma, because of their experience in various systems, and because they have felt like they've been marginalized or oppressed, they've probably learned along the way to distrust the system and to distrust folks that represent the system. So you may not always know that this is the type of trauma that they've experienced until you gain that trust from them and show that you're a caring and compassionate person. And so really just want to hone in on that point that I think we'll reiterate throughout today, which is, we don't always need to know the source or cause of their mental illness or their mental wellness being in crisis. We really just need to observe those behaviors and try to figure out how we can support them in the best way possible. Okay, next slide. We're just going to do a quick overview of mental health, what it means when we're talking about mental illness, just get into that definition, and then get even more into what Patricia said about how to support folks and how to recognize some common illnesses. Okay, so first, just so we're on the same page, next slide, just want to ask the question to you all. If anyone wants to share and they feel comfortable, what is your definition of mental illness? What do you think of, or what are the first words or thoughts that come to mind when you hear the word mental illness? So if anyone wants to share that in the chat, this is, no wrong answer here. It's really just about making sure we're all on the same page and speaking the same language. So when you hear mental illness, what do you think? Trauma, absolutely. Yep. Any other thoughts? Be one word, doesn't have to. Not looking for the textbook definition. No other brave souls? Okay, well, thank you, Olivia. Yeah, trauma is absolutely connected with it. So on the next slide, you'll see we're just giving a very general definition of what mental illness is. And it's really about, we're not talking about somebody who all of us can probably relate to experiencing depression or feeling anxious or other things that are often common associated with mental illness. But when we're saying that someone has a mental illness or a serious mental illness, we're really talking about a diagnosable illness, just like diabetes or high blood pressure. But for mental illness, this really is going to get this diagnosis, it really means that it has to impact the way you think, the way your emotional state, your behaviors, and really the way we like to talk about it is it impacts your ability to do the 4 L's, to live, love, laugh, and learn. And so really, if you're trying to support somebody or you think somebody is struggling with a mental illness, it's taking stock of that. Like, are the behaviors or symptoms that you're observing impacting them in any of those 4 L's in a significant way? If the answer is yes, then this is a clear sign that somebody might be struggling with a mental illness. We don't need to know exactly which one perhaps, but at least start to engage them in a way to find out how we can support them, because you're noticing that they're struggling with these 4 L's is really the important thing. And we're absolutely talking, when we talk about mental health, substance use or substance use disorder is absolutely something that we're talking about, and Patricia will talk a little bit about what that means when you see it co-occurring. Okay, so next slide. I just want to do a quick true or false. If folks are brave enough to answer this, you can throw it in the chat quickly, but true or false? Oh, it's a poll. Awesome. The most prevalent mental health disorder, so it's anonymous. You don't have to worry if you get it wrong. The most prevalent mental health disorder in the US is anxiety. What do you think? Quick answer, gut reaction. True or false? Okay, we got a lot of trues, a couple falses. Awesome. At least half of you responded. Okay. Thanks, Holly. We can end the poll. Yeah. So most of you are saying it's true. A couple of you say it's false. And I think I know why some of you might think it's false, but on the next slide, you'll see it's actually true. It is the most prevalent one. Actually, specifically, almost 20% of adults will experience an anxiety disorder in their lifetime. That's what that percentage is telling us. And then you'll see the next most common one is depression. So, throughout these disorders, it can be episodic, it could be persistent, long lasting throughout their adulthood. But the reality is 20% of us, or 1 out of 5 of us almost, are going to experience anxiety in our lifetime. And, there's several different forms of anxiety, which we don't need to go into, but really, we just want to reiterate here just how prevalent some of these mental disorders are, these mental illnesses are, just to give you a sense of what you most are likely to experience. And I know for a lot of you who are working in housing or behavioral health and healthcare, navigating folks that are unstably housed or on the streets, you may, when you look at it, in that subpopulation, schizophrenia often feels like it's much more prevalent. And so when I share this data a lot with folks in the homeless or behavioral system, they're surprised how not prevalent schizophrenia is when you're looking at the general population. But as we'll talk about later, when you think about the signs and symptoms or behaviors that you're likely to see with somebody who's struggling with schizophrenia, then you can see how they are going to be directly lead to homelessness, hospitalizations, incarcerations, and so on. And so that's why in that subpopulation, we probably see it. It probably feels much more prevalent and is probably a majority of what you may be experiencing. But when we look at it broadly, it's not so much. Also, just in this context, we want to note that many of these mental illnesses really begin, the symptoms of those really start to take place and shape when someone is as young as 14. And at least half of them will show signs by the age of 14. And then the majority of folks will actually show these signs clearly by the age of 24. And so it's really, really important to note that, just because as I think about the folks that I've worked with, and if you're thinking about folks, especially the aging population that you encounter that may have an undiagnosed or untreated illness, to think about how they've gone several years struggling with these symptoms, struggling with managing their behaviors on their own, without a clear diagnosis or treatment. And so I think it's really important that we recognize that. Because it's all the more reason that they're going to need your support and your compassion and your patience as they struggle and figure out for themselves what's going to work best. Okay, next slide. Just a little bit more data too about the mental health and older adults. As also, these are just some key statistics that we want to just frame our discussion moving forward with you all to better understand how to serve this population. So globally, we're seeing that the population is aging rapidly. Between 2015 and 2050, which is just around the corner if you think about how fast these past years have gone, the proportion of the world's population is going to be over 60 years old. And it's going to nearly double from 12% to 22%. And so that's a significant amount. So the better we can understand the aging process and how people's mental health is impacted is the better equipped we'll be as a community and people who are working to support our community, how better to support them. And so it's really important that we recognize mental health and well-being is very important for older and as people age throughout their lifetime. And mental health or neurological disorders among older adults can account for 6.6 or almost 7% of the total disability for that age group. So it's still a big percent of folks that are going to need this extra support. And then lastly, about 15% of the adults over 60 will suffer from a mental illness. So again, really seeing that there is a need and it's only going to grow in the next couple of years. Okay, next slide. So just want to pause and get your feedback. Thank you, Karen, for saying, that you're seeing that prevalence as well, but would just love to hear from you all. What are some of the negative impacts of mental illness that you're seeing your clients or tenants struggle with? What are you noticing? What are some of the challenges you're experiencing with folks? If you feel comfortable, would love to you just put it in the chat. It is a smaller group, so if you guys are like me and you process better verbally out loud, just raise your hand and you can go off mute, but just want to hear your initial thoughts about what you're seeing out there. Yes, absolutely, Ariana. Yeah, struggling with undiagnosed illness and refusing that they have an illness, right? And if you think about, folks who've managed it for years, it's hard for them to wrap their heads around that they do have an illness and actually need the support. Not to mention all the stigma that comes with, mental illness. Oh, thank you, Cynthia. Yeah, problems with relationships, unable to care for themselves. Yes, absolutely. Cognitive distortion. Yeah. Oh, yeah, that black and white catastrophic thinking. Thanks, Gretchen. Yeah, that's a challenge. Absolutely. Okay, keep them coming in. Keep your thoughts coming in. Any questions? We'd love to hear them for sure. Well, thank you, Andrea. Yeah, trauma, depression, absolutely. All of these things we're going to see. And so I think a lot of these we're going to dig into and even talk about how you can support folks and engage folks that are struggling with that. But without further ado, I'm going to turn it over to Patricia, who's going to dig even deeper into these illnesses.
Thanks. Next slide, please. And Karen, we will talk a little bit about kind of crisis, de-escalation, crisis intervention. So hopefully we can answer your question later on, but feel free to remind us if it doesn't come up. So now we're going to talk a little bit more about party hat, yay, working with people with serious mental illness. So as I mentioned before, we're going to go through some of the symptoms, diagnosis, and we're going to really do this through case studies. And really case studies representing people with anxiety disorder, bipolar disorder, major depressive disorder, and schizophrenia. So, and just a quick note, these case studies and this work that we're going to be doing right now is not meant to diagnose anybody. So we're not in the, most of us are not in the field to diagnose anybody, but it's really to understand how the symptoms are impacting that person you're working with. So what are the things that you need to look out for that something's up with John, or I think Maria is behaving in a way that it looks like she's escalating to some sort of crisis. So really thinking about that in that context. And also we're going to weave in some components around the aging process, right? I think one of the biggest concerns that we have around working with people with behavioral health needs that are aging is that kind of overlap between cognitive disorders and their behavioral health symptoms. So we'll talk a little bit about kind of how to identify each of those and how do you work with clients who do experience specifically dementia as they are aging. Next slide. So in recognizing a mental illness, it's important, as Ari had said before, it's really to take a look at the changes in psychological, behavioral, and physical well-being. So here you have some symptoms, and I'm sure you guys have seen a lot of these in the people that you're working with, but some symptoms can include all of a sudden an inability to cope with daily life. So really struggling day to day to really function, to make decisions, some suicidal thoughts, right? Some, irregular emotions that are really unstable. So really, and confused thinking, right? So like starting to recognize that something might not be right with the client. These are some signs. Next slide. In particular, in talking about a serious mental illness, it's something that we kind of, put a stronger emphasis on because they're really critical needs that this population does need. And you guys know, working in the homeless system and working in the housing system, how prevalent things like schizophrenia are and bipolar disorder. So just wanted to talk a little bit about serious mental illness, or SMI as we commonly refer to it. So it's defined as a mental or behavioral or emotional disorder resulting in serious functional impairment. And that interferes with people's activity of daily living and interferes with friendships, with jobs, employment, those kind of things. And this is the burden of mental illness is particularly concentrated among those who experience disability, right? So it's almost it's like their problem to resolve, but these folks are the ones that need the most support. So as I mentioned, we're going to talk about anxiety disorder, bipolar disorder, major depressive, and schizophrenia. Next slide. So another quick poll, as we talk about serious mental illness, kind of psychosis comes up quite a bit. So, which of these symptoms are common for someone with psychosis? Hallucinations, delusions, cognitive experiences, all of the above. Yeah, you guys totally got it. We can end the poll here. All of the above. Yeah, and they look different for everybody, right? So I'm going to go through kind of what each is and maybe share some examples. And please feel free to share examples in the chat of what you've seen with your clients. Next slide. So for people with serious mental illness, psychosis is a common trait, and it could be really scary to see someone in a psychotic episode. You've probably seen that as you're working with people in crisis. I know I've seen it working in an inpatient psych unit. It really is scary. So how do you kind of understand what's going on with that person so you're better able to manage help them manage their symptoms and then create more of a safe place for them? And a lot of times these psychotic episodes they do lead to hospitalization, right? Because it might be so extreme that they're unable to care for themselves or really be, they really need that attention or medication adjustment, et cetera. So what are the psychotic symptoms? So hallucinations, these are when you see, hear, or feel things that other people don't. So for example, hearing voices, seeing things which other people do not see, feeling someone touching you, smelling things which other people cannot. So the most common out of these is hearing voices. This is the most common hallucination, and it's often different for everybody. So they might hear a male voice.
You came early. Oh man.
Sorry, and just a reminder, you could mute yourselves unless you're gonna chat with us. So they can hear voices, like it could be somebody telling you what to do, which is really scary, and they're called command hallucinations. And we often get really worried if somebody is hearing that because it can lead to actual, true kind of violent occurrences. Honestly, sometimes I rarely have seen people with, feeling things or smelling things. If you have a client that might be experiencing that, the first thing you need to do is get them to a doctor, right? Because they might have something else going on that might not even be related to their mental illness, right? It might be some sort of cognitive or some sort of other issues. And we'll talk a little bit about kind of medical issues and as it relates to people with mental illness. Delusions, these are beliefs that are not based in reality, even though they feel so real to the person that is experiencing them. A delusion is not the same as holding a religious or spiritual belief which others don't share. So some examples are that you're being followed by someone's trying to poison you or hurt you, that you have people putting thoughts, different ideas and thoughts into your brain. I worked with a client that often thought that other people from a different government were communicating with him, and he was terrified of this. So the experience is very real. And you may find these experiences distressing, and then sometimes they're not, right? Sometimes people deal with this, and this is kind of always how they function. They might always have a paranoid delusion around the government, for instance, but if they're able to function within that, that's okay. And I think, in talking about what, the important pieces are, is how do you support them? Not necessarily tell them they're wrong, not tell them we don't believe you, but really, we understand that this is hard for you. How can we support you to feel better? And then finally, cognitive experiences. So there are ones that relate to mental actions, such as learning, remembering, and functioning. So this could be some disorganized thinking, right? A client who might be kind of all over the place and really can't form quite a good sentence, or issues with making decisions. So there are lots of examples that I'm sure all of you guys have really seen in the clients you work with. And I just want to comment on Karen's chat. I truly believe during COVID-19 pandemic, mental illness increased, as well as the importance and awareness of mental health and what it looks like. And totally agree with you, Karen. And I think we'll likely see some research on this that's going to highlight that at some point in the future. Next slide. So as Gretchen mentioned earlier, you're going to have access to all these slides, so I'm not going to go deep into this. I think it's more, interesting to learn through the case studies, but just, overview of each of these illnesses. So for generalized anxiety disorder, we know that occasional anxiety is part of everyone's life. However, anxiety disorders involve more than a temporary worry. It's a consistent worry that really could be detrimental for in the person's life and can affect their daily living. Some symptoms are feeling restless, fatigued, irritable, a lot of somatic symptoms, meaning like you feel it in your body, right? Because you're feeling anxious, you might have a headache, those kind of things. And really the treatment options, it's a good combination of both therapy and medications for these folks, especially therapy that's called cognitive behavioral therapy, which is really helping you think through your thoughts and how those thoughts influence and impact your behavior. Next slide. So now I want to read a case study, and then we'll have a little mini discussion around it. So Mary is a 55-year-old woman who lives in supportive housing. Mary has no significant medical needs. Mary regularly complains of feeling stressed all the time and constantly worries about everything. She says that sometimes she is so worried and stressed that she's unable to sleep at night. She also frequently lashes out at her case manager. Lastly, whenever Mary feels stressed, her shoulders and head often hurt. So kind of based on what you know about anxiety disorders, what are some symptoms that you see Mary experiencing here? Again, feel free to put them in the chat or come off mute. Anger, problem sleeping, yep, not able to sleep, insomnia, stress. Body tension, yep, body tension is important. Sometimes, I think we don't have the words sometimes to explain how we feel, but we feel it, right? So it's really critical to pay attention to our clients when they're experiencing this kind of body discomfort, because it could mean something else. Yep, the physical aspects, lashing out, exactly. So as a case manager, if this was your client that came to you and said, this is what's going on, like what would be your response, or how would you help her? Yeah, I think that DMH is probably connected to the Department of Mental Health. So look for some sort of support. Sometimes some other options could be just as simple as stress relaxation techniques, things like that. Have her check with a physician. Exactly, it could be something medical going on. Tell her that she has support. And it looks like Karen has her hand raised. If you want to come off mute.
Sure, thank you. I would generally just assess how she's feeling overall. Where is this anxiety deriving from? If possible, identifying the barriers. What are some of the root causes to this? So just probing a little bit further and discovering more.
Exactly. Is this a new thing? This has just come out of nowhere? Is this how she's been feeling for months? Did her medication change? Something happened in her family? So exactly, Karen, just ask more questions to really understand. And you're asking the questions, again, not for any diagnostic purpose, but like what's really going on and how do I connect it to the best service? So thank you for that. Next slide. So mood disorders are pretty prevalent in the population we work with, and kind of some of the most common ones are depressive disorder and bipolar disorder. So depressive disorder, so depression is common, but it's a serious mood disorder, and I think people sometimes underestimate how serious it can be for folks. Again, it causes severe symptoms that affect how you feel, think, and handle daily activities. There are definitely different types of depressive disorders and how they develop, right? It could be postpartum, it could be phobia related and such. But in talking about just regular depressive disorder, some of the symptoms are, feelings of sadness, right? Irritability, feelings of hopelessness, difficulty concentrating. So a lot of the symptoms that would mimic kind of anxiety disorder. One of the usually the scariest symptoms that you hear is people who have suicidal thoughts, right? That really is a cause for concern and action. And we'll talk more about how do you handle those cases a little bit later. And depression, really can be treated, and a lot of people can live fine with a depressive diagnosis, but not have it interfere with their life. And you do that through individual therapy, medication, support groups, and the like. So if we want to move to the next, case study. So John is a 56-year-old African-American male who is divorced with 2 children and lives in a shelter. John has a history of diabetes. John recently reported that he's been feeling lonely, sad, and has little energy. Additionally, he says he's become increasingly forgetful. John recently had some weight, has lost some weight, and reports trouble eating and sleeping. Lastly, John has a history of multiple suicide attempts in the past. So first, what are some symptoms that he's experiencing? So I definitely see a lot of kind of emotional, right? So sadness, feeling lonely, loneliness and depression, weight loss. trouble eating, hopelessness, forgetful. Yeah. So, I think for this, like what are some other questions you should ask based on his symptoms and based what of people who might have depressive disorder? What are some really critical key questions that you should get as part of your assessment? Duration, yep. How long has this been going on? Complete PHQ-9, and for those who don't know, is a depression screening. Is he managing his diabetes properly? That's a big one, right? When you have low blood sugar, you can look really different. Check for suicidal ideation and whether he has a plan. If so, needs serious intervention. Exactly. Anybody who has a history of suicidal attempts, really it's important to kind of talk with them about if they have any plans and what that looks like and what kind of level of intervention you need. I think another thing is here, this is kind of where us, while 55 doesn't seem like, an aging, particularly like an aging person, we think of 60 and older, but for the population that's experiencing homelessness, they often get a lot of symptoms of aging very early on, just given the trauma of homelessness. So, thinking that, is there something cognitive going on, right? Does he need to see maybe a doctor to really talk about kind of the issue with concentration? Is there something medical? Is there something neurological? So kind of paying attention to these things are critical. Again, a lot of the symptoms of aging and disorders really look alike. So it's kind of hard to tease, but important to recognize always the physical elements, always the aging process, in addition to kind of the symptoms that are being presented from a mental illness. Yeah, and Karen also said recent losses, changes. And what would you recommend would you do next? We already kind of talked a little bit about it, but what would be some immediate next steps after this? Yeah, Leticia said, discuss other additional barriers that may be triggering physical, emotional symptoms. And some next steps. I know we said it sounds like maybe there's something with his diabetes, so maybe checking in with a primary care doctor. Maybe just having a visit. Yep, get a complete physical and assessed by psych. And of course, as someone mentioned in the chat before, if there is a suicidal plan, really understand what that is, and if it requires a level of intervention like a hospitalization, really get that done. That's the primary focus here. Great. Next slide. So bipolar disorder. So this is probably one of the most misunderstood disorders, and something that people just kind of throw around like, oh, just, mood issues, right? Like that person's bipolar, but it's actually more complicated than that. And I'm sure if you've worked with clients or have had experience in your family or even with yourself experiencing bipolar, you can see how complex it is. So really, if you have a mood disorder, your general emotional state or mood is distorted and is really inconsistent with what's going on in front of you. And again, like bipolar is one example of a mood disorder, but there's also major depressive, seasonal affective disorder, depression caused by substance use or medication. And for bipolar disorder, there are really 3 types of bipolar disorder. I'm not going to go too much into them, but bipolar 1, which includes manic episodes and depressive episodes. So just for you guys, I'm sure if you ever seen somebody in a manic episode, you know exactly what goes on, but it's this heightened hyperactivity, really risky behavior, some irritability, kind of feeling untouchable. You can kind of do whatever you want. And I've seen somebody in a manic episode, it could be really scary. And then, that kind of follows by periods of depression lasting at least 2 weeks. Then there's bipolar 2, where you get both manic and depressive, but it's less intense. So it's not full blown manic episodes, but maybe like, you might not be sleeping for 3 days because you're a little bit manic, not necessarily, going off a week without sleeping and doing all sorts of risky behavior. And then psychothymic disorder. So it's really periods of this hypomanic episode as well as depressive symptoms and they're ongoing for at least 2 years. And, with bipolar disorder, we see a lot of psychosis, anxiety, misuse of alcohol and drugs, and also eating disorders. And treatment really, bipolar disorder is a lifelong illness. So it really, requires kind of that long-term treatment that could be a combination of therapy and medications. Next slide. So let's talk about Jamie. Jamie is a 45-year-old white woman who is unemployed and lives in an apartment by herself. She was found on the street talking to herself and looking disheveled. When approached by a local mobile crisis team, she was speaking so fast she was difficult to understand. She did say she hadn't slept in several days and recently used drugs after being sober for 3 months. The mobile crisis team ended up sending her to an emergency room for further assessments. So based on this case, what are some symptoms that you clearly see she's experiencing, and how would you help her? And as people think about it and enter things in the chat, right, kind of sounds like maybe some psychotic symptoms, right? If she's talking to herself, maybe she's hearing voices. If she's disheveled, maybe she hasn't been able to really take care of herself. Did something happen that kind of caused this episode? So I think it's a lot more assessment. I think, having the mobile crisis team work with her and then maybe getting her admitted to a hospital could be a good opportunity to really decide what's going on. Sometimes when there's a mental illness and there's a substance use need, it's hard to tease out the two. So really an inpatient hospitalization is the right place to do this, just to make sure that both disorders are being treated. And if you feel like adding anything else to this case, please enter in the chat. And then we just want to jump to the last one, which is schizophrenia. And schizophrenia, next slide, is a serious mental illness. And people with schizophrenia may seem like they've lost touch with reality, and it causes so much stress on families and on the person themselves. A lot of the symptoms of schizophrenia typically fall into 3 categories: psychotic symptoms, negative symptoms, which are kind of like including a loss of motivation, a loss of speech, those type of things, and cognitive symptoms that really affects the concentration and attention and decision making. And again, like bipolar disorder, these are often long-term illnesses that do require follow-up. So some people do live really well without medication. Some people need medication for life, but I think it's really important to also provide kind of coordinated care for this type of person, just given the severity of their illness. And then the final case study. Bill is a 59-year-old white male who lives in transitional housing after living on the street for 20 years. He's usually pleasant and agreeable to meet with his case manager. Over the last couple of weeks, Bill has become very agitated and has been quite distant from other people in the building. He's been pacing back and forth, seemingly talking to himself with cotton balls in his ears. Upon the case manager visiting his room, she notices the windows were covered up and his room was very messy. He said that he needs to leave the housing program soon. So what are some symptoms here? What are things that would be cause for concern for this person? And please share in the chat if you ever had a client who put cotton balls in their ears because they were experiencing significant auditory hallucinations, and that was a way for them to try to control it. Check to make sure he's taking prescribed medication. Yep. Again, did something happen, right? Like, was there some sort of trigger that kind of, he's covering the windows. Like, what is kind of the paranoia about it? Is it safe for him to be there? Again, is this leading to him really not being able to take care of himself and need some sort of intervention? But I would say this kind of sounds like a typical person that I've worked with in the past, and I'm sure you've experienced a lot of these folks. And it's really just about trying to keep them safe and really helping them connect to services. And even if, again, people with long-term illness are in and out of treatment, maybe they are not taking medication anymore. Maybe their symptoms are getting worse. Maybe some event happened. This person, 59 years old, is getting older, kind of putting all those things into consideration to help you think about what are the next steps. Next slide. So thank you guys so much for working through these case studies. I hope they were helpful, and I hope they were really relevant in a lot of the work that you do. So just to note about co-occurring disorders, so that's when there's a substance use disorder and a mental illness. So we commonly see this in people with a mental illness, and a co-occurring disorder is a diagnosis specifically of a substance use disorder and a psychiatric disorder. So, and we know that substance use is a disease that affects the brain, and affects then and leads to behaviors that might have an inability to really function, to control their use of an illegal substance or medication. And about half the people who experience a mental illness will also experience a substance use disorder at some point in their life. And really kind of 3 reasons why we see this occur is kind of the areas that are affected by both in the brain, by both mental illness and substance use are kind of affected when there's a use going on or where you have a mental illness, right? So there's like those overlapping factors, like real genetic factors that are in the brain. And then also sometimes there's environmental influences, right? So like early exposure to trauma and stress can lead to both these disorders kind of coming into play. Secondly, we know that people self-medicate, so mental illness can lead to drug use and substance use, right? So if somebody is diagnosed with a mental illness and they're feeling anxious, they might not see their provider, maybe they'll use some medication, maybe they'll, use drugs to help compensate with that. So we see that quite frequently. And then finally, substance use and addiction can contribute to the development of mental illness. So it can lead to some changes in the same, as I mentioned before, in the same areas of the brain where there are other mental disorders. And it can exacerbate symptoms. So if you have schizophrenia and you're using, it's going to exacerbate those symptoms, or it can kind of start creating those symptoms and trigger really kind of a psychotic break in some people. Next slide. So true or false, research shows that substance use is an increasing problem among older adults. Yep, so and the poll, we got some people. So yeah, it's true. Next slide. It's true, and oftentimes people forget about aging people and substance use, but just a couple of highlights here that at large, there's an increasing number of aging adults who are also dealing with substance use disorder. Adults with substance use disorders have higher hospitalization, leading to more complex kind of healthcare needs. There are psychological changes that occur with aging that puts older adults at a higher risk when they use substances. So for example, issues with liver functioning, which has additional consequences for individuals living with or at risk for Hep C. So there's like physical things that are going on in the body that substance use can exacerbate. And also prescribed medication and alcohol can lead to adverse effects. So specifically binge drinking can increase the risk for falls and negatively impact existing chronic conditions. So we do see that big overlap here. Next slide. And just kind of honing in a little bit more about the older adult population when it comes to behavioral health needs, we know that they have increasing needs as they get older. So we talked about premature aging. People who are getting older sometimes might have accessibility challenges, right? So they can no longer walk the 5th floor walk up. They might need a 1st floor apartment. They might have issues performing ADLs, like using the bathroom and things like that. Risk of increased medical concerns. So we'll talk a little bit more about that in the next slide. Risk of institutionalization. So a lot of folks end up in nursing homes when they don't need to be in nursing homes, right? Because their healthcare needs have become so complex. Increased mental health needs, limited services for geriatric mental health, and that's a huge one that we'll talk a little bit more about. Isolation and loneliness, and cognitive decline, including dementia. So I'll highlight a couple of these just so you can get a feel of what exactly the needs are there. Next slide. So as far as, every person who's aging faces a lot of, unfortunately some medical conditions, but it becomes even more challenging when somebody has a mental illness because they might not be able to communicate that well. There might be so much stigma around mental illness that doctors don't even kind of pay attention. There might be, less time spent in primary care or ambulatory care to really address this, medication adherence. So some things that we see is, there's decreased kidney and liver function. Bladder infections or urinary tract infections are really important. And it's something I want to note because sometimes when people, especially older adults, get a lot of urinary tract infections, they look like they might be having some sort of, like confused fugue state or some weird symptoms. And people might think it's related to kind of dementia or cognitive decline or even kind of exacerbations of a mental illness, but oftentimes it's just the symptoms of having that UTI. So really thinking about this population and their medical needs is very critical. We see decreased memory, medication and appointments not adherence, falls, impaired balance, and then multiple chronic conditions. Next slide. So another poll, dementia, true or false, is a normal part of the aging process. Perfect, and you guys are good. It's false. A lot of people think it is part of it. So next slide. So I'm not going to go too deep into dementia because it is a very complex illness, but basically it's the loss of cognitive functioning, thinking, remembering, and reasoning to an extent that it really interferes with the person's daily life and activities. Dementia is more common as people grow older. About 1/3 of all people age 85 and older may have some form of dementia, but is not a normal part of aging. So when you see these symptoms, recognize that this is a separate, it's not like, oh, this person's getting older, that's where they're becoming forgetful. Really recognize that it's a problem. And there are different forms of dementia, which we won't go into, but just know that dementia in the US is growing. So right now there's 47 million people with dementia, and we estimate by 2030, which is not that far out, that 75 million people will be diagnosed with dementia. So it's a really common issue. Next slide. And these are some of the warning signs, right? So, and again, it's confusing because some of these signs are very similar to people with a mental illness, but being attuned to the client's needs and what their behavior is can help you determine whether this is something that is a cause for concern. So memory changes in planning or solving, difficulty completing tasks, confusion, trouble understanding. So a whole host, and these are kind of the 10 top warning signs. Next slide. And if you really see any of these, it's critical that the person sees a doctor, right? I think oftentimes we forget and say, again, it's part of the aging process, but really early diagnosis is really important. So make sure when you work with your clients that it's part of their discussions with their PCP, with their screenings. And then what can happen is there could be, if there is a diagnosis of dementia, really working on putting a plan that addresses their medical, their psychosocial, and whatever their co-occurring illness and conditions are. So you can really have a comprehensive way of supporting this person. Next slide. And somebody mentioned earlier in the chat, but this kind of notion of isolation and loneliness, that is part of people's experiences with mental illness, but it's also really increasingly common among older populations. So just for a little context, so isolation, it's really an objective understanding. So it's the separation from people, community, and resources. So somebody, again, who's in the 5th floor apartment and can't go down the stairs, that person is isolated. Loneliness is really more subjective, right? So it's associated with feelings of being alone or separated from network supports or social connections. So you can be with lots of family and friends, but you feel that sense of loneliness. You don't feel connected to those things. It's estimated that among people aged 65 and older, about 5 and 16% report loneliness and 12% feel isolated. Both loneliness and isolation pose health risk, which increases in acuity for people as they age. And then we do know that these factors have been exacerbated by COVID-19, and they haven't really gone away fully yet. So it's something always to keep in mind. And as you'll see on the next slide, there are some very common concerns for social isolation. So there's risk of depression, anxiety, cognitive decline, heart disease, weakened immune system. So these are all things to really take note of as you work with adults in general, but particularly the aging population that's becoming a little bit more isolated. And someone just mentioned having peers and friends who pass away also can contribute to loneliness. Yeah, that's exactly right. So I'm going to pass it to Ari, who's going to talk through crisis intervention and de-escalation for a bit.
All right, thank you, Patricia. This is so good. I'm enjoying this training. You guys are I'm appreciating your interactive and thoughtfulness, so thank you. So yeah, as Patricia said, I'm just gonna talk a little bit more about crisis intervention and de-escalation strategies, and hopefully address, I think it was Karen's question earlier about, working with somebody and if there is a challenge in getting them the support they need. So let's get to the next slide, and just want to review some key steps to helping folks. And I think, again, the goal is that we're remembering whether a situation has de-escalated in your crisis situation, or you just want to engage somebody who you're noticing is struggling with mental illness or dementia or any of the things we've already covered today. The key here is just, we're trying to engage them, support them, and get them the support that they need, right? And so I think some of these key steps should not be such a surprise to many of you, but just more of a reminder that these things apply even in a crisis, or even if somebody is really struggling with a behavior or symptom related to mental illness or cognitive difficulties. And so, again, as always, we want to approach them with kindness, and as much as you can, really identify the concern, the specific behavior or the specific observation that you noticed. Again, we want to use that active listening skills. We're trying not to be judgmental. We've talked about the stigma these folks might be experiencing, the lack of trust they may have in others. And so really making sure that we authentically are to demonstrate that we're not judging them, that we're just there to support them, is going to be really key as well. And please ask for help, right? We don't need to solve anyone's problems. We're definitely not going to solve the world's problems alone. And so we really need to make sure that we're really cognizant of when it's clear that we are going to need extra help, that maybe what we're doing, our engagement techniques aren't working. And so it's really going to be important that we ask them for help. Karen, I really appreciate your emojis. I feel like I'm interacting with you silently. And then also, encourage the individual to ask for help, right? You don't have to be the end all be all, but maybe, ask them, who's helped you before? Or what have you done in the past to get help, and encourage them to do that again is really going to be the important piece there. We don't want to tell them, oh, you need a therapist, or, oh, you need to go see your psychiatrist. No, it's, asking them what they want to help and encouraging them. Last time you saw your psychiatrist, did it help? Or you were not satisfied with the medication? Yes. Okay, well, maybe we should have a discussion with your psychiatrist and talk about that more. I'd be happy to help you and support you if you're worried or concerned about that. Again, it's really important that we maintain our boundaries, not only to take care of yourself, because I'm a big advocate for self-care in this work. It's emotionally and cognitively taxing on us as the helpers, as the people that are trying to support folks. And so maintaining boundaries is really going to be important for that, but it's also important for the client. We want to make sure that they're not over-reliant on us or any one individual. We're trying to build their own resiliency and their own ability to self-care as well. And so, maintaining these boundaries is going to be really important, and not doing too much for them, not overstepping. And we'll talk about how really that's significant too, if you start thinking about the aging population, where we might be working with a lot of people that are older than us, and so needing to maintain that is going to be really important. And in all of this, if we're trying to build that supportive relationship, build trust, we've got to do that with making sure we set realistic expectations. We're not promising that we can do anything. We can't promise that they're going to feel magically better tomorrow. We can't promise any of that. But what we can promise is that you're going to continue to support them. You can promise that you'll go back to the office and do some research on some resources. You can tell them that you're going to check in with them, maybe later in the day, but only if you know for sure you can, right? And so making sure we're consciously and constantly, taking account to what we really can say we can or cannot do for tenants is going to be, or clients is going to be really important. And always, respecting those cultural and individual differences, as Patricia walked us through. It's going to look different for a lot of people. Culturally, there's a lot of things that impact the way people ask for help, the type of help that they're interested in. And so we've got to constantly respect that. Going back to that, cultural humility and that non-judgmental approach is going to be really important. Okay, on the next slide. So those are kind of just general tips, right? What if things get escalated? What if somebody starts to get really upset and they start yelling or doing these other things? Again, keeping all that still in mind, trying to be that supportive, non-judgmental communicator. One thing is really important is if things get escalated is to have that self-awareness and situational awareness and know when to ask for help. I really stress this too, that you want to do this, before things get really or beyond out of control or beyond your ability to de-escalate. It's really important that you always are kind of aware, or you have a plan with your supervisor, your colleagues, about how you're going to get that help or how you're going to get that support at the first sign or first signal that somebody's feeling upset. You really want to make sure that you're getting that help before you completely feel unsafe, just to maintain your safety and the safety of the client is what I always advise folks to do. again, you know, if you think about, I always tell people, put yourself in your shoes. If you think about when your emotions are really high and you're really upset or you're really frightened and scared, that fight or flight, you know, going on with our bodies, there's a lot going on with our minds racing. It's really hard to focus on anything complex or any type of multi-step direction. So it's really, really important as things start to escalate and you see somebody getting emotionally elevated that you really, you know, slow down. You want to speak confidently, you know, you don't want to waver, but you also really want to make sure that you're showing a very caring tone and that you're and they're using very simple, slow, simple words, simple terms, and you're doing it a little bit slower. You know, you don't have to start really talking really slow, but, you know, just making sure you're not talking as fast as like we've probably been talking today because we're trying to get through the content. But, you know, recognizing that it's going to be hard for them to process things. So you're going to have to repeat yourself. You don't want to use jargon, and really make sure that you, as much as possible, can stay calm and manage your own nervous behavior. So again, that self-awareness, that self-care is going to be really important because you want to be that duck on the pond, right? I like this analogy because I think it really mimics what people often feel. And I felt when I'm in situations and I'm trying to de-escalate, which is you want to, you know, the duck looks like it's just gliding over the pond, right? But you don't see underneath the water that they're vigorously paddling their feet, you know, and it's going crazy underneath them for them to be so smooth. So as much as your heart may be beating and your breath starts to feel short, you know, as much as you can take some deep breaths and still stay calm while your mind is racing and you're trying to figure out the next word or the next step that you're going to take with this person, just be cognizant of your nonverbal skills, all of those other things that you're doing. Yeah, and as Patricia's saying, we all get triggered. So it's really important to be aware of that and communicate that with your colleagues and even the client in advance. I've had clients where we've had to sit down and say, we are not going to accept certain words or we're not going to accept certain behaviors. And so if you do, this is what we're going to do. This is why I'm going to remove myself from this situation. It's going to be really important. Karen, sorry, I see your hand. Did you want to add something or you have a question?
Oh, thank you. Also, in terms of acceptance level, when we're addressing the member or the individual, you know, while we're assessing, we're also considering where they're at, right? Cognitively, mentally,
Right.
physically, emotionally. Are they ready to hear the truth?
Yeah.
You know, and we're presenting truth, right? We're being as transparent as possible, but are they really, you know, actively listening to what we're transmitting?
Absolutely. Yeah, couldn't agree more. Thank you for bringing that up. Yeah, it's really true. And I always tell folks too, especially like as you assess where they are, and especially if things are getting escalated, you know, now's not the time to maybe educate them on the appropriate behaviors, or now's not the time to like try to tie it to a specific, you know, really the goal is to get things back to calm and quiet and for everybody to feel safe. You can certainly engage them and communicate to them some of these truths, as Karen said, that they may need to hear or you know is going to help them get the support that they need. Maybe later, right, where things are calm or in a different situation, or when you have a supervisor or colleague there to support you and you feel safer too, is always a good best practice. I always stress it's the best thing you could do for de-escalation is all the pre-crisis work, all the work that you do in advance to know the individual, to know what stimulates them, what doesn't stimulate them, and then to just, you know, even have those conversations. If things get escalated or you start using these words or your voice gets too loud, I'm going to have to back up or I'm going to call for support, or, you know, really making sure that it's clear and everybody knows what to do. And then also on the next slide, just want to reiterate, in these situations, if things start to get escalated, someone starts to speak faster, you can hear their voice getting louder and louder, they're starting to curse and use these words that you know is a sign that they're really upset. Wait for the break. This again, now's not the time to be right. Now's not the time to be the all wise and knowing or you know, super clinician. Now's the time to just, you know, let them get out what they need to get out as long as you feel safe. People eventually are going to have to take a breath, eventually pause to think of the next word. And that's always the more appropriate time to maybe speak up. So really the key too is to be patient. You know, I had a tenant that would escalate very quickly, but she also de-escalated herself almost just as quickly. So we had to learn that about her and recognize that jumping in was only going to make things worse. We'd let her get out whatever she needed to get out. And when she calmed down, that's when we would communicate like, Yeah, so when you called me that word, it's not a good word for me, and it really makes me feel upset. It makes me feel not respected. And so let's talk about some other words you can use when you're upset. Not in the middle of it and correcting her right on the moment, but waiting for it to be calm is going to be really key there. I think people often forget that, and you get excited and you want to say something. And I've been in that situation, end up saying the wrong thing and making it worse, right? So give yourself that own patience and grace that you're giving your patients or your clients, and making sure that you give yourself time to breathe, come up with some words, dig in the back of your head for those kind of catchphrases or back pocket phrases that you always use to help calm things down or communicate what's happening in the moment. And then next slide, just want to reiterate, I think you all know this very well, but just reminders, what's not so helpful in those moments. Be very mindful of your attitude, trying to keep it positive. I know it can be hard in those situations. So as much as you can, keep a neutral or more positive attitude, the better. Again, reiterating the boundaries, just professional boundaries, but also thinking physically about where you're positioned yourself. Not blocking exits, making sure that people feel like they're not being very restricted. And then you don't want to take the other person's, abilities or sense of self away, right? So we're not going to start telling them what to do or telling them how they feel. Continue to ask questions and be curious and not necessarily judgmental or thinking of consequences. And then last but not least, we talked about this, but we're not going to recommend or suggest certain treatments right now or in the moment when people are upset. Really, it's about asking them questions and really trying to be there and as supportive as possible. So again, we can get to that calm. Okay, so quickly just want to go through a case study, get your input and think about what does this actually look like in practice? And this is actually very close to a real situation that I had, so I wanted to walk you guys through it. So you have Sheila, who's a 68-year-old woman, and she's just moved into her new supportive housing unit. She's in recovery and she's struggling to stay on top of her medication regimen. She's got a lot of complicated medication she's on for both physical and psychiatric reasons. And this usually leads to her psychiatric, symptoms coming back, feeling delusional or paranoid about other folks, or thinking that folks are against her. And she's easily upset and struggles with managing her anger. And so during a home visit, you've got a new case manager there that's trying to engage her, and as we all want to do, and asking her about her next doctor appointment and where his location is. And because she's got so much going on, she forgets, can't remember, but then quickly turns to thinking that the case manager is against her. And maybe the case manager is asking these questions because they're trying to trick her or whatever. And so she starts yelling, gets really upset. You see the case manager is visibly upset, maybe shaking or, looks really nervous. And you're there as their partner, or as the person they're shadowing. What would you do in that situation? How would you engage Sheila? Or how would you support your fellow case manager? Just would love your initial thoughts. And I agree, Karen, self-reflection it has to start there, right? We have to be aware of ourselves and what's going on. Any initial thoughts about how you might engage with Sheila in that moment or de-escalate this situation? As you see clearly your coworker is struggling. Yes, I love that, Cynthia. So you're problem solving right there in the moment, right? So you want to step in, say, I can help you, with that information, and let's write it. It's, hey, we all forget, you know what I do to remember my doctor's appointments and locations? I write it down. I have the whole thing on my whiteboard or on my refrigerator. Would that help you? Yes, absolutely. So the key is, trying to step down, trying to be, supportive, but also you can really do that. Yeah, absolutely, Marissa. Make sure that you're provide some silence, but also showing some empathy, for Sheila. She's clearly struggling and needs some support. Absolutely, Andrea. We're going to continue to speak slowly and closely. Yes, Karen. Yeah, self-disclosure. I'm assuming you're talking about me saying that. Yeah, we've got to make sure we can share a little bit, but not too much. But just getting them to see that you're there and you're trying to support them. Yeah, Cynthia, I would take some deep breaths too to make sure I'm calm, and then also encourage and support the case manager. Maybe model that for them so they can see how you can do that in the moment. Yeah, and she doesn't know this new case manager, so it's not, why would she be so trusting? It's not totally unrealistic. Thank you for pointing that out. So that's really going to be important to recognize that and and try to support them, especially if you know Sheila. You've done the work, you've built that trust relationship. So hopefully in the moment, you'll feel more confident being able to support her in a way that the new case manager may not. And she'll be more likely to respond to that. Great, thank you. Yes, and coming back, making sure you call her PCP and do it together is a great way to show that collaboration and that mutuality with them. Absolutely. Thanks, folks. Okay. For the sake of time, just want to move on to the next slide because I want to be able to give Patricia some time to talk a little bit more about some treatment options. But we just want to recognize that in these escalation situations, there is going to be a point where you need additional help. As I said, hopefully you've done that pre-crisis work, you've talked to colleagues, supervisors, and you have crisis teams that you can call to get that support. But sometimes you don't have a choice, especially when it hits some of these indicators that we've put on there where you're worried that the person is harming themselves, you think they're likely to harm you, or if they've done serious, property damage, all these things that we know is clear that you're going to need emergency services, whether it be medical or law enforcement to come and intervene. We just want to always caution folks about calling 911, especially in this environment. Be very aware of what that means in your community. And if you can do any pre-work to engage law enforcement, your local fire department or ambulance or hospital to make sure they understand what this means when you're calling 911 and the type of support you're expecting is going to be really helpful. And even talking to the individual too, saying, I've called 911, they're going to be coming, and really talking them through to that. Yeah, absolutely call the crisis team first is always the recommendation. And then of course, we don't want to say anything that would contradict your agency's policies, whatever you have set up in terms of what to do in these types of situations you want to follow, whether it's contact supervisory staff or other folks within the agency first is going to be really important. Okay, and then just some quick notes I want to make on the next slide. We're just going to transition into what this means with engaging older adults who also need mental health. So on the next slide, we just first want to, reiterate, and some of this we've talked about already, but there are some unique challenges when you're specifically working with older adults who have a mental illness, right? As somebody already articulated, they may have fewer social supports around, right? Because they've seen people in their lives pass away or struggle. And so they may have less people that are living close to them or living in general in their lives that they can rely on. They may have a longer history of limited work and, subsequently not have that financial support that they may need to thrive in their community. If they've lived a long life of being without a home and transient, an instability in those services, they may not know how to engage services on a regular basis because they've never had that stable environment to do so. They definitely may have learned a lot of behaviors that are not as health promoting as we'd like, and so making sure that there's going to be a lot of coaching and maybe relearning that they're going to have to do after a longer history of maybe not treating their mental illness as they should. And then with all that we've discussed too, with these physical chronic illnesses that they may have, how that can impact them as well, not just physically, but mentally and emotionally. And they may be more aware than we are, of the higher mortality rates as they've seen their loved ones and their friends pass away or struggle around them. So recognizing all of this, all these cognitive symptoms and mental health symptoms is going to be really important as we engage them. And so just on the next slide, just want to remind you all, they deserve the dignity and respect just that we all want and that any other client would want, and so being very aware that there are some unique stereotypes for the aging population that we don't want to fit into, we don't want to fall into or reinforce. And so it's going to be really important that we do that. I had a tenant once tell me, she really was upset that a lot of people assumed that she didn't want to work or that she was going to be this grumpy old woman when she was trying to advocate for better services. And so really making sure, just like anybody else, we're listening to them non-judgmentally, very cognizant of our tone. Even though we may need to speak in more simple terms, that doesn't mean we have to be patronizing in our tone. We still talk to them like we would talk to anybody else with that same tone and try to continue to reassure them with the support that they need. Okay, next slide. Just a key general communication guidelines. I think a lot of you guys know this already, but and we've gone some over it. A lot of it's going to be similar to what we talked about when it's that being very mindful of how we communicate and what we communicate with others. And so again, making sure we're speaking directly to them. We're very clear about what we're going to do or what we're trying to communicate with them. The next steps, why we're calling their PCP with them together is going to be really important. I think also it's important to really make sure that this includes our nonverbal language as well. So to think about when people, are struggling cognitively to follow your directions or hear everything that you're saying, they may default to just also making judgment or making calls based on your nonverbal communication. So as much as you can be cognizant of that and make sure you're not, squaring off with them or showing any kind of nonverbal communication that makes them feel that you're not listening or you're not being authentically supportive is going to be really important, because people can often, most times actually in general, people often respond more to your nonverbal cues than the actual words that you're saying. So we have to be very cognizant of that at all times. That eye contact, that open stance, is really going to be important. And then, really wanting to make sure that, we focus on these short-term goals, really, giving them some key feasible steps that they can do is going to be really important. And then considering all the tools that can help them, that you can offer them with checklists, helping them write things down, all of those things that we know are going to be important and to help support them along the way is going to be important. Okay, so now we're going to transition on, if you go to the next slide, a little bit to navigating treatment. And so I'm just going to review a couple key things and then hand it over to Patricia. So one thing on the next slide, we just want to reiterate, right? If things do get in, yes, assistive technology is always helpful too. When things do, worst case scenario, and you do have to call, or somebody does get hospitalized, whether it be for mental health or physical health reasons, I should just say health in general, regardless of what the reason is really making sure that the focus is going to be on ensuring that they have some discharge planning and recovery post that hospitalization, right? We want to make sure that their safety and their transition from the hospital is going to be as smooth as possible. So just some key things that you can think about when you're partnering with the care team or the treatment team when a client is hospitalized. If possible, we always want to obtain that consent before or ASAP, before they are hospitalized, or as soon as possible. So you are able to then interact with them, contact them and have some of those conversations that are going to be really helpful. A key part of that is, making sure you get in touch with that social worker who's working with them and who's probably going to lead that discharge planning process. It's going to be key because they're going to really rely on all the information that you may be able to provide that the client is either unable or unwilling to provide, because you've been working with them, you observe them in their home or in other settings that they may not be able to understand or observe while they're in that short stay, because oftentimes it is a short stay, right? So I know we always tried in previous jobs to really contact them and get in contact with the social worker or care team as soon as possible, or at least one in the first 24 hours that the person's hospitalized, to let them know we're here, we want to be a part of that team, we want to help transition, and that we've got any information and can support them as much as possible. You always want to also go and see the tenant, right? This reinforces this relationship that you've built with them, but also being there physically is going to help obtain the consent if you need it, but also interact with that care team. That physical presence is always really important, I think, is as much as we can. I know it's harder during a pandemic and maybe impossible, but if you can, it's going to be really helpful. And then, start the discharge planning as soon as possible. Engage the treatment team, figure out what they need in terms of documentation, what documentation you can help and support them with, and constantly coach the tenant and the treatment team and help be that conduit or help be that extra support for that person is going to be really helpful. Because again, they're going to really benefit from you giving them this information and being that extra support for that individual. Okay, next slide. And then one thing that's also really important in this is really making sure that you think about, even before they're hospitalized, but absolutely after, it's part of that discharge planning, is coming up with a crisis or safety plan, right? And so this is really just, may look different depending on your organization, or you may already have a tool or a template that you use, but some common components of the plan, just to think about how can you really lay it out with you and the client about what is going to keep them safe once they return back to their unit or to their home, is going to be really important. So, talking with them and recognize about what are some warning signs that they are in crisis, or they may need some additional supports, is going to be important. It's being as proactive as possible, agreeing on what are some coping strategies that they want to engage in. So you can remind them, remember you said that taking long walks helps you. So let's make sure that you're constantly doing walks. These are things you can check in with them regularly on. hopefully finding ways that they can socialize with friends or family, identifying key supports in their life, whether it be family, mental health professionals, or others that are going to be there. It's all part of this plan that is going to help keep them safe. And then also, as much as possible, how they can set up their environment so they can feel safe in their home and in their community. So oftentimes that's about removing, or avoiding certain stimuli, putting up things that make them happy, reminders, anything that's going to help make them feel safe is really important. Okay, next slide. And then I think you all know this, but this is just more of a reminder. There are a ton of different ways that people can get supported for their mental health, right? Sometimes it is therapy, sometimes it is psychiatric treatment, but there's other types and other forms that people can get. And so the reminder is just for you all is that we need to remember that it can be varied and there can be a mixture or all of these that people need to support them. And we need to just really constantly explore that with the person to figure out what's going to be best for them. Asking them what's worked before in the past, offering them, other options, saying, have you ever considered, exercise? Have you ever considered, maybe changing your medication? Just constantly engaging them in that way is going to be important as we find and work what works best for them in that moment. Okay. I'm going to turn it back over to Patricia now, who's going to talk more about some treatment options.
Thanks. So we're in the final stretch. So I think it's important to recognize, particularly for people who are older and have behavioral health needs, that there are barriers to accessing treatment. So for one, there could be lack of age-appropriate services. So I've heard oftentimes, there's a substance use group and I am 60 and everybody's 20. That there's a, that might make people feel uncomfortable, or there's lack of integrated care where they're looking at both their physical health and their mental health. Again, stigma, we've really talked about, especially for this population. We also talked about how older adults with serious mental illness are at increased risk for untreated medical needs. So it's really difficult to get them the right diagnosis at the right time. There's a lot of complexities with treating co-occurring conditions. So we hear this often, just like how do you treat the substance use versus the mental health? How do you work with them together through integrated care? And then probably most importantly, the lack of geriatric mental health providers is huge. So I think, this takes a very specific skill set to be able to look at somebody comprehensively, and we have a lack of services in that area. So really leveraging what you have in your community will be helpful, and we'll talk about that in a minute. And then just in general, right, you don't need to really go into this, but there's a hospital inpatient setting for acute care. If someone needs more long-term care, there's state hospitalization for those who have significant behavioral health issues. There's residential treatment, which are usually short-term based treatments for substance use programs or mental health residences. And then there's, of course, outpatient treatment. Next slide. And we have trainings at CSH on a lot of these models, but just to highlight a few evidence-based models that are really critical. And one, just to kind of call out how assertive community treatment is a really good model, especially for people with severe mental illness, just because you get this comprehensive team that can kind of follow you anywhere, right? And we often have clients that have very siloed care, whether that's in the healthcare system, mental health, or substance use. So kind of an ACT team helps put the pieces together a little bit. So it's one that I would recommend if looking at your clients and their needs. But the rest we have trainings on that, so you can learn a little bit more. The next slide, really, sometimes I think in supportive housing, our clients are aging, right? We need to face the fact that they might need help in the home. So how do you support people with complex needs? By working with home care, by working to look at their insurance and seeing what their managed long-term care plan is. How do you navigate that? And we have a whole another training on how to navigate that, because it really is complicated. But just to think, right, if somebody might have a home health aide, how do you work with them? They're usually not trained in working with people with behavioral health issues, right? So how do you have some harm reduction approaches to that? How do you engage them? And the PACE program is really kind of like an ACT team for medical, right? So it's like a comprehensive treatment team for people with complex medical issues, and we'll give you some resources about that towards the end as well. And then the last thing I want to just talk about, I think as we look at in the next slide, as we look at people who are aging, we don't want people to be prematurely institutionalized. There's too many people in nursing home settings that are just there because they're homeless, are there because nobody has really gotten them the community supports. So how do we ensure that people are aging in place? So really understand when people say higher level of care, like what does that actually mean? Like what kind of care do you mean that they need? What resources are available in the community that have not yet been explored? Like you say they need a nursing home, but have you ever tried home care? Have you ever tried a PT? Have you ever tried kind of all these other resources? What is the goal of the move? Is it that, you know, they're in a supportive housing building and they are in a walk-up and there's no elevator and there's really no other capacity? Is that the reason why you're moving them into an institutionalized setting? And then lastly, and most importantly, what does the client want? And we know that it's sometimes complicated because they might not know what they want, or it might be at odds with what we want, but really trying to engage them in that process is super critical to kind of ensuring that people are thriving in their communities. And then if you could look at the last couple of slides, is some resources that are local to your area. So the next slide really talks about that PACE program that I was mentioning. That's a really good innovative program and really pairs well with people in supportive housing and people who have complex medical needs. And of course, there's the Housing and Community Investment Department, Accessible Housing Registry. So when you look at the need for accessible housing for people, you can use that resources. In the next slide, you'll see some Department of Mental Health resources that are specific to people with severe mental illness. And also there's some geriatric specific programs here. So I'd recommend you guys take a look at it. And then lastly, you know, the crisis line, National Suicide Hotline, websites that might be useful. And again, you'll have copy of all this so you can really take a look and, you know, see what resources are relevant to you. And then finally, I know we kind of flew by this, but you know, we can stay on for any additional questions, but please tell us how we did. So if you go to the previous slide, you can do the QR code and do the survey, but we're also going to send a survey out when we send the slides. We really want to know what we did well here, what topics are you're more interested in to hear from us about. So we're always trying to really listen to kind of what the needs are out there in the community. So with that, really thank you and happy, and Ariana just shared it in the chat as well. So you can kind of go right there and do it. But if there's any last minute thoughts, questions, anything you'd like, we would be happy to stay on for a couple to hear those.